Hi, good morning, good afternoon, good evening, everyone. Welcome to this webinar on accelerating anemia actions. First, I would like to let all of you know that we have simultaneous interpretation in French and Spanish. And when you look down, there's an icon, looks like a globe, and it says interpretation. And when you click there, you can choose your preferred language. There will also be interpreters providing additional instructions in our chat function. So please feel free to use the chat function as well. So with that, I would like to formally kick off the meeting. My name is Mandana Rabi, and I'm the Vice President of Global Technical Services and Chief Technical Advisor at Nutrition International. And I'll be helping to moderate the webinar today. The key objectives from today's event are first, to update you on the progress towards some of the key nutrition for growth commitments on anemia that have previously been made. We also want to discuss the importance of a multi-sectoral approach to addressing anemia globally as a global health problem. And also, we want to encourage participants to express interest in joining the Alliance for Anemia Actions and one of its work streams. Next slide, please. Thank you very much. A few administrative points. As I noted, we have simultaneous interpretation. Please also ensure that you're logged in with your full name and affiliation so that all the participants can know you. And already we are building this alliance, so it would be good to know each other better. You can use these three dots that show underneath your picture and use the rename option and then add your name and affiliation. You can use the chat function at the bottom, as I noted, introduce yourself and write any general comments you have. And you can also use the Q&A function to ask questions for speakers. I also would like to let you know that the session will be recorded and made available online after the meeting, and your participation also will be recorded. So with that, I would like to start by introducing our first speaker, Dr. Francesco Branca, who is the Director of the Department of Nutrition and Food Safety for the World Health Organization. Francesco has led the development of the WHO nutrition strategy. He has established a new nutrition guideline development process and has developed a comprehensive implementation plan for maternal, infant, and young child nutrition with 6 global targets. And Francesco, it's my honor to hand over the webinar to you to start providing us a tribute to 2 wonderful individuals that the nutrition community has lost in the past year. Over to you.
Yeah, good morning, good afternoon to all. This first task I've been given is not a pleasant task. It's a sad task. But we thought that it would be important to do this. I mean, you have met these colleagues before, so we have sadly lost these 2 individuals who have made important contributions to public health and to the fight against anemia. And so just allow me to take a little time to recognize them and their accomplishment. You know, first, Dr. Mwele Malesela. She was the director of the WHO's Department of Control for Neglected Tropical Diseases. She was previously the director in the office of the regional director, WHO Regional Office for Africa in Brazzaville. She was from Tanzania, and among the most well-known and respected researchers, scientists, and public health leaders in Africa. Dr. Malesela dedicated her life to improving the health and well-being of the most vulnerable. She advocated for the empowerment of women, for gender equality, and for the welfare of women and girls. She also was a champion in encouraging and inspiring youth to study science and to serve the cause of global health as viable and vital avenues for realizing their talents. Dr. Malesela will be remembered as an inspirational figure, a dedicated leader, and a committed listener, and a nice person full of spirit. And the second colleague is Dr. Freulema. He was in many of our meetings before. He was Ethiopia's leading voice and nutrition expert. He was a public health physician with a PhD in public health nutrition. He was the country focal point for the UN Scaling Up Nutrition Movement and the senior nutrition advisor to the Minister of Health. He held major leadership roles in the development of national nutrition policies and guidelines, including the National Nutrition Program and the Secota Declaration. Last October, only last October, Dr. Lema led the development and submission of Ethiopia's bold, ambitious commitments to the Nutrition for Growth Summit. Both of these leaders in their respective fields will be remembered for their incredible contributions and are missed by all of us. So we really would like to dedicate this event to them both and let them be our inspiration for accelerating actions to reduce anemia. Thank you, and over to you, Mandana.
Thank you very much, Francesco, for those kind words of remembrance for the two inspirational individuals and nutrition champions. I would like to now hand over the floor to two esteemed Assistant Director Generals of the World Health Organization for the opening remarks. We will start by Dr. Naoko Yamamoto, Assistant Director General of WHO's Division of Universal Health Coverage, Healthier Populations. Previously, Dr. Yamamoto held the role of WHO's Assistant Director General for Universal Health Coverage and Health Systems, and she brings nearly 30 years of experience working on health in Japan and served as Senior Assistant Minister for Global Health in Japan's Ministry of Health, Labor and Welfare. Dr. Yamamoto, it's an honor to have you with us. The floor is yours.
Thank you, Mandana. Thank you. And I also thank you all colleagues for this opportunity to share progress of our Nutrition for Growth commitment with you today. Back in November, I announced WHO's commitment to develop the global action plan to prevent and manage anemia in women and children. WHO and UNICEF, together with the frontliner group of countries and partner organizations, also committed to establish Alliance for Anemia Actions to support the implementation of the Global Action Plan. This is an extremely important public health issue. Globally, almost 1 in 3 women and 40% of young children suffer from anemia, with the most affected in Africa and Southeast Asia. However, very few countries are on track to meet the global target to reduce anemia in women of reproductive age by 50% by the end of 2025. But there is also positive news. There has been the progress since the Nutrition for Growth Summit in November. First, almost 400 new commitments were made by 181 stakeholders across 78 countries. Over 1/3 of these commitments address women's nutrition, maternal nutrition, and/or gender equity. However, only 9% of all stakeholders committed specifically to reducing anemia. Second, WHO has created the Interdepartmental Working Group on Anemia to oversee the development of the Global Action Plan from multiple perspectives, including nutrition, maternal and child health, sexual and reproductive health, malaria, neglected tropical diseases. Third, WHO, UNICEF, and partners are building the foundation of the Alliance with Anemia Actions, and we speak, and Francesco will update you on our progress. We are excited that Alliance will bring together actions from multiple sectors to contribute to action that reduce anemia in women, adolescents, and girls and children. We cannot do this alone. We need your participation to ensure voices from multiple areas of the world are heard, and that together we translate the good intentions and commitments into concrete efforts. WHO remains committed to working with partners to reduce the prevalence and severity of anemia as part of our shared effort to build a healthier and safer future for everyone, everywhere. So thank you very much. Back to the moderator. Over to you.
Thank you very much, Dr. Yamamoto, for this strong expression of commitment and encouragement. I would like to now turn to Dr. Ren Mankui. Dr. Ren serves as Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases Division at WHO. In this role, he oversees a complex portfolio of technical programs covering HIV/AIDS, viral hepatitis, tuberculosis, malaria, neglected tropical diseases, mental health, substance use, and non-communicable diseases. Dr. Ren has spent nearly 30 years working in public health, including as Director General for the International Cooperation in the National Health and Family Planning Commission of the People's Republic of China. Dr. Ren, again, it's an honor and a pleasure to have you here with us, and handing over to you for your remarks.
Thank you very much, Madana. It's such a pleasure and a privilege to be here today, along together with all the colleagues, Special ADG Naiko Yamamoto. The high burden of anemia, particularly in low-income countries, is such important issue that we must urgently address to achieve the Sustainable Development Goals for health and to achieve health for all. That's exactly why I'm so pleased to see the progress in the development towards a global action plan for the prevention and the management of anemia, and the progress towards the establishment with UNICEF of a new alliance for the anemia actions. Anemia is indicators of both poor nutrition and poor health, and is the hallmarks of many of global health inequities that we see today. It is related to the micronutrient deficiencies, but also related to the infections with many infectious diseases, including malaria, hookworms, schistosomiasis, HIV, and TB. Lower social economic status, low education, and the higher levels of gender inequalities are also highly linked to the anemia as well. People with anemia in turn have a serious health condition, and also economy and development challenges, including in the increased risk of infections and deaths, and the low cognition, extreme fatigues, and the poor pregnancy outcomes, and the loss of hearing and the poor growth and development. These are serious inequalities that we must act on now. WHO is committed to supporting all the countries to progressively expand access to essential health services and nutrition services as a part of their journeys towards universal health coverage. Universal health coverage is based on the principles of access to quality health services for everyone, and the rich and the poor, and the healthy and the sick, and the younger and the old, and everywhere along the life course without the fear of financial hardship. To reduce the burden of anemia and achieve the universal health coverage, we must build and maintain strong, resilient health systems that can prevent, screen for, diagnosis, and treat anemia. Now it's time to recognize and intensify our work to achieve the progress towards global nutrition target and the 2030 agenda. This also requires strong leadership and coordinations at the global, regional, and local levels. It requires all of us and all of you working across multi-sectors to play our part. So we are looking forward to sharing information with you today on the progress made and opportunity for you to contribute to reduce the global burden of an anemia. With that, thank you very much.
Thank you very much, Dr. Ren, for emphasizing this multi-sectoral nature, excuse me, of anemia. And it's encouraging to hear you emphasize the link that there is with, for this work with the universal health coverage and universal coverage of other services that we need to have across various health costs. So I would like to come to our next speaker, Dr. Omar Dari, who will be providing the keynote address for today's webinar. Dr. Dari is a senior nutrition advisor at USAID. And speaking of nutrition champions, he has worked in public health nutrition from basic research to strategic planning at national and global level. And his major areas of expertise are micronutrient assessment and food fortification. USAID leadership in nutrition is exemplified by the multi-sectoral action, multi-sectoral anemia task force, which was established in 2011. To increase the coverage of anemia prevention and control interventions among pregnant women and children under 2. And then it has received even more attention in the multi-sectoral Advancing Nutrition Flagship Project. Dr. Dari, over for you for your keynote address.
Thanks, Mandana, for the introduction. Hello, everyone. It is very nice to be with all of you today. I am including a lot of technical information in this talk, but I hope that you can follow me, and after hearing it, you are going to have new views about anemia. Anemia is a consequence of many diseases, and at the same time, anemia causes other health problems. Go back to the first, please. Regrettably, anemia, like child stunting, is perceived as an easy indicator to assess and to change, while the truth is that it is difficult to interpret and to manage because of its multifactorial determinants. In USAID, we have worked for the prevention and treatment of anemia for more than 50 years, but the slow rate of real progress made us rethink our approach, as doing more of the same was not going to work. Thus, 3 years ago, we supported the creation of Anemia Task Force to advise our project, USAID Advancing Nutrition, in this matter. My talk is based on some of the recommendations of this technical body that focus in work in 3 areas: biology, assessment, and translation. The World Health Assembly of 2012 endorsed the target of reduction of anemia prevalence in women of reproductive age by 50% by the year 2025, and which has been proposed to be extended to the year 2030 as one of the Sustainable Development Goals. A similar objective was established in the year 1990, when public health nutritionists committed to reduce the prevalence of iron deficiency anemia by 1/3 by the year 2000. But nothing happened, and we need to analyze why. These failures have not been because of the lack of interest. For example, USAID in 1975 created the International Nutritional Anemia Consultative Group that contributed many scientific findings, methodologies, and technologies to prevent and manage anemia. In the year 2008, it merged with other micronutrient technical groups into the Micronutrient Forum, because we realized that preventing anemia and other consequences of micronutrient deficiencies needed an integrated approach. Now, evolving in our thinking, we are supporting the Anemia Task Force, and with the aim to help us to prevent anemia, and not only nutritional anemias, because those are closely related. Next slide. In this sense, we need to realize that anemia is not a biomarker, but a very high-level bioindicator of the well-being of a society. Unlike biomarkers, a bioindicator is the result of the combined effect of many different causes. In the past, we placed our attention on improving the diet, especially the supply of iron, under the assumption that this way was the easiest and more direct manner to prevent anemia, to the point that we call any anemia iron deficient anemia. We supported several interventions, from biofortification to food fortification to micronutrient supplementation, barely thinking that all of them were the same solution, that is supplying more iron, although through different platforms. Impact of these interventions depends on iron bioavailability. However, this is still insufficient. 20 years ago, we discovered that iron absorption is highly dependent on the physiological conditions of the host. We learned that hepcidin is the main hormone that regulates iron metabolism. Hepcidin halts absorption and mobilization of iron when iron stores are adequate. However, it also does the same thing when the organism is infected, to prevent pathogenic organisms from accessing iron, which is almost required by them. While this is a way to fight the infection, it may also cause iron deficiency and some anemia. Disease-favorable conditions, such as those created by poor sanitation or the presence of parasites, press human populations to select traits that decrease the suitability of the red blood cells to be infected, and those genetic characteristics also cause anemia. Thus, we need to pay attention, not only to the diet, but also to the genetic and health status of the population. And adding to these complex interactions, we need to realize that hemoglobin concentration, and therefore anemia prevalence, is also determined by the characteristics of the environment. Next slide. Over the last 5 years, we have identified problems in the epidemiological assessment of anemia, and it is the discrepancies in prevalence values estimated in different types of population surveys. This figure shows the evolution of anemia prevalence in preschool-age children of Jordan, determined by using finger-pricked blood, that is the blue line, and using venous blood, that is the red line. The results of these 2 types of surveys suggest very different conclusions. There has not been progress in anemia measured with finger-pricked blood, but when hemoglobin is measured with venous blood, a reduction of 40% in the prevalence of anemia from the year 2002 to the year 2019 has occurred. We have seen similar situation in other countries, and now USAID, Nutrition International from Canada, and the Public Health Institute of Mexico are leading a multi-country study to search for the reasons of these results. We are expecting that this study is going to provide recommendations to assess hemoglobin in a reliable manner in population surveys. Nevertheless, knowing the prevalence of anemia is insufficient. We also need to determine the causes. In this example, only 43% of anemia is linked to iron deficiency. Here, it is important to point out that iron deficiency could be absolute or functional. Absolute iron deficiency is when the body iron stores are insufficient to satisfy the metabolic needs. Functional deficiency is caused by the presence of infection or inflammation. Thus, we need to differentiate between the two types of iron deficiency, and which is a very difficult task. Moreover, we also need to identify the other causes of anemia. As we already heard at the beginning of this conference, determinants of anemia can be both non-nutritional and nutritional, as well as genetic traits that originated to create resistance against certain infections, especially malaria. That said, micronutrient deficiencies continue being important determinants of anemia, but these not only include iron, but also folate and vitamin B12 that are required for the synthesis of hemoglobin. Vitamin A and vitamin B2, among others, are also needed for maintaining balanced metabolic settings for hematological and immunological functions. We usually do not carry out comprehensive assessments to investigate anemia etiology. Some pioneer efforts have been done, and this is one in this slide, the micronutrient survey for Malawi. Iron deficiency was estimated in 8%, but megaloblastic anemia, in this case mostly linked to vitamin B12, was equally important. In Malawi, the parasitic diseases are at least as serious as absolute iron deficiency. This population also has many genetic traits that reduce the concentration of hemoglobin as an adaptation to survive in this malaria endemic region. It is important to point out here that supplying more iron to overcome this nutritional inadequacy is still insufficient, as the impact might be limited because of the impairment of iron absorption and utilization due to the infections. Next slide. To end, let me to summarize the ecological approach that the Anemia Task Force has endorsed for the translation and implementation of the scientific findings. Interventions for preventing and managing anemia must be directed to two main groups of factors, either to improve the production of red blood cells or to reduce losses. For the latter, control of infection and inflammation is needed. And for the former, in addition to that, the improvement of the nutrient quality of the diet is also required. Next slide. And for achieving these two objectives, countries must pay attention to several areas of work, such as ensure food security, strengthen maternal and child care, guarantee health services, promote good dietary and hygienic habits, and improve safety and sanitation of the environment and of the water and the food supply. Finally, it is important to understand how the different conditions of the environment are determining the genetic traits and the biomarker values of each specific context. The phrase, one size does not fit all, is applicable both to the selection of the interventions as well for the interpretation of the epidemiological data. The last slide. In conclusion, anemia prevalence is a high-level bioindicator whose causes are both non-nutritional and nutritional. Some of the non-genetic causes are amenable to public interventions, but those are context-specific. Therefore, actions to prevent anemia must be based on carefully assessment of the local etiological factors. Increasing the supply of iron and improving its dietary bioavailability are insufficient to prevent iron deficiency and its contribution to anemia in populations that suffer of constant infections and inflammation. Perhaps the world has progressed on the reduction of anemia prevalence, but it has not been recognized because of the use of inappropriate assessment methodologies. Together with the multi-sectoral measures to prevent and manage anemia, it is important to improve the diagnosis of anemia and the associated determinants, as well as to monitor their changes in response to the program performance. Let's work together in this Alliance for Anemia Action, applying scientific evidence, critical thinking, and reliable monitoring for addressing effectively and efficiently this global health problem. Thanks for your attention.
Thank you very much, Omar, for laying out the task ahead of all of us so clearly, and especially emphasizing this research, learning, and evidence agenda that we all need to be supporting in order to be able to address the gaps that we are facing in addressing anemia in future. So now I would like to turn back to Dr. Francesco Branca to provide us an update on the progress that we've made towards the 2 commitments on anemia that were made as part of the Nutrition Growth for Summit last year. Dr. Branca, over.
Well, thank you very much, Vandana. And if I can have the first slide, this is really following up on what Omar has already said. I mean, the fight to anemia has a long history. And the most recent one really is the establishment of these 6 global nutrition targets in 2012 by the World Health Assembly as part of this comprehensive implementation plan on maternal, infant, and young child nutrition. The rationale for that target, 50% reduction of anemia in women of reproductive age compared to that baseline of 2012, was the understanding that some countries have actually been able to achieve a reduction. And so this is a target which is ambitious but realistic. Lately, the prevalence of anemia in women of reproductive age was also adopted as an indicator under the Sustainable Development Goal 2 on zero hunger, really indicating, giving another dimension of the objective to really reduce all forms of malnutrition. So as Dr. Yamamoto was saying in her introduction, WHO together with UNICEF made an important commitment at Nutrition for Growth. And that was to develop an action plan to prevent and manage anemia in women and children, seeking to improve efforts in reducing both the prevalence and severity of anemia and to advance the global nutrition targets. But then there was also a second commitment, and that was to establish an alliance for anemia action jointly with UNICEF and other partners. Next slide, please. As you heard from Omar, I think the narrative needs to change, and it needs to recognize that there are multiple causes, risk factors, and drivers of anemia. And therefore, the objective of the Global Action Plan on the Prevention and Management of Anemia is to work collaboratively with a broad group of partners and stakeholders to provide strategic, effective, and implementable actions to achieve the global nutrition targets on anemia reduction and achieve better health and well-being. So in WHO, we've put together, we've convened an interdepartmental working group on anemia, and then we've been seeking inputs from relevant partners and stakeholders from multiple sectors. We're very grateful, for example, to the WHO Strategic and Technical Advisory Group for Maternal, Newborn, Child, and Adolescent Health and Nutrition, and you have one of the members here today in the panel, to decide to give attention to the topic and create a subgroup. But also, we would like to really see opportunities for engagement with region and countries. Next slide, please. Now, the Global Action Plan will have 6 priority areas, and we're now collecting input papers to provide a situation analysis on the current evidence and knowledge gaps for 4 of these priorities. Number 1, the diagnostic of anemia and its causes, and you heard from Omar the challenges of that diagnosis. Second, preventive and therapeutic interventions to reduce anemia. Third, determinants of anemia. And fourth, integrated management of anemia across the life course. But we're also interested to understand what kind of science challenge, research challenges exist. And also, we would really like to understand what kind of expectation there is on integration and coordination for these different areas. So we are really looking for collaboration of the interdepartmental working group on anemia to prepare these papers, so they should be ready in the next weeks for public dissemination. So we hope that with these spaces we could develop at least a draft of the action plan later in the summer, and that would be the basis for our further discussion. Next slide, please. So the Alliance, in support of the implementation of the Global Action Plan, WHO and UNICEF, with the partners you see around this virtual table today, are committed to establish a cross-sector alliance for anemia action. And the idea of the alliance is really to be an inclusive platform to bring together all relevant stakeholders across disciplines, sectors, geographies, with wide country representation. So the idea is to catalyze progress in anemia reduction by learning from country experiences, driving cross-sector action. The Alliance will build on and leverage the experience and expertise of leading initiative on anemia reduction. And you know, some of these initiatives have been mentioned by Omar. Since January, a core group of stakeholders has worked on building the scaffolding of the Alliance in a collaborative manner. A stakeholder landscaping was carried out, an initial governance structure developed, principle of engagement defined, and 4 work streams are proposed. I must say that the landscape is complex, and it depends on our narrative. Our understanding that anemia is such a complex condition really will lead us to the selection of appropriate actors which have not been working with us on this important common undertaking. The proposed work streams are 4. So there will be an integrated research agenda to address biological assessment and programmatic issues that constrain progress in anemia reduction. An investment strategy to foster global and domestic investments, encouraging more government donors and philanthropic foundations to invest in anemia research, and the development and implementation of comprehensive integrated national plans to prevent and manage anemia. We'll have national integrated anemia action to support countries that commit to accelerate progress. And we will have a programmatic implementation of existing recommendation on the assessment of anemia and risk factors and the evidence-based intervention for prevention and management of anemia. And my last point is about the structure of the Alliance. So the next slide, that we will have a core group of stakeholders, 4 working groups based on the work streams and the steering committee. We'll have a lean secretariat to support the working group and steering committee in terms of administrative and coordination support. And we also would like to see a stakeholder forum to have participation by multiple actors, including, you know, the relevant actors from relevant non-state actors that could really contribute and would like to be kept informed of the activities of the Alliance and could provide a contribution. We really would like to work on this Alliance with you, on building this Alliance with you. So we'll now finalize our governance, our principle of engagement, and we aim to launch the Alliance in September with the steering committee, the working groups, and a diverse core group in place. Thank you.
Thank you very much, Francesco. It's really great to hear the progress that has been made towards these N4G commitments in this relatively short amount of time. And we are all looking forward to continue supporting your leadership and all the colleagues' involvement in moving this initiative further forward. So with that, I would like to now move to our panel discussion. I also wanted to briefly mention that this webinar is being recorded, and I know that, you know, the talks are fast-paced and there's a lot of rich content. So do make sure that you use the recording afterwards if you want to come back to some of this content, and it will be made available to all the participants. I would like to introduce the moderator for our panel, another nutrition champion and a great colleague, Dr. Saskia Ossendorf, who is the Executive Director of the Micronutrient Forum. Saskia, over to you.
Thank you, Mandana, for a very nice introduction. Before I introduce our panelists to you today, I would like to express how pleased the Micronutrient Forum is to have worked with the WHO and UNICEF and all our partners over the past months towards the establishment of this Alliance for Anemia Actions. And we're really looking forward to continuing our support to this alliance because, as you can imagine, it's at the core of what the Micronutrient Forum's vision of a world free of micronutrient malnutrition. I would like to encourage you all to pose your questions for the panelists in the Q&A box, which you can find at the bottom of your Zoom screen. And if time permits, we will be able to ask some of these questions to the panelists at the end of this live session. So speakers and panelists may also answer your questions in the Q&A box by typing in their responses directly. So with this, I would like to introduce you to our panelists, and I would like to ask the panelists to please turn on your video and your microphone when I introduce you so that you can be seen on screen to everyone. And we will have two sets of questions to the panelists. The first are related to the problem of anemia, experiences of the panelists in addressing this complex global problem, which has been introduced to you by Omar Dari in his keynote lecture. And a second set of questions relate more to how this proposed Anemia Alliance that was introduced to you by Dr. Francesco Branca, how this can help you in your work. So with this, I would like to introduce the first panelist today, who actually doesn't need an introduction. I think he is Dr. Sulfikar Bhutta, who is a co-director of the Center for Global Child Health at the Hospital of Sick Children in Toronto, Canada, and a founding director of the Institute for Global Health and Development at Aga Khan University in Pakistan. Sulfi is a distinguished academic, a leading researcher that has been leading research projects such as the work on anemia by the exemplars of global health. Dr. Bhutta, I'm very pleased that you will join us on the panel here today. Our second panelist is Mylène Paradis, who is the Director for the Health and Rights of Women and Girls Division at the Global Affairs Canada, GAC. And I would like to especially mention that Mylène agreed to step in at the very last moment. So we were really pleased that you were able to join us here today. And then our third panelist is Dr. Bharati Kulkarni, who is a senior scientist and head of reproductive biology, maternal and child health, and the nutrition department at the Indian Council of Medical Research. And as such, Dr. Kulkarni is directly involved in India's country-wide multi-sectoral Anemia Mukt Bharat program. Then our next panelist, Mr. John Raqpa, unfortunately has not yet been able to join us today due to connection problems, but if he is able to join during the course of this panel, we will of course introduce him to you because he is joining us from Nigeria and has a lot of experience in leading micronutrient programs. Our fifth panelist is Dr. Dylan Walters, who is the Director for Health Economics at Nutrition International. And his work focuses on developing and leading health economics research, evaluation, modeling, and policy projects related to maternal and child nutrition. Previously, Dylan contributed to the development of the Nutrition Investment Framework, which is developed by the World Bank. And then last but definitely not least, Mrs. Sumra Qureshi, who works as a team lead at the Knowledge Management and Digital Innovation Unit, Nutrition Division at the World Food Programme. Sumra has worked at the WFP's Pakistan office, their regional office of West and Central Africa, and is now at the headquarters in Rome. So a warm welcome to all the panelists. And I hope everyone can see the panelists in the screen. So I would like to kick off now with the first round of questions to each of the panelists to explore what we know or what we do well, as well as to identify gaps and challenges that are still existing in addressing this complex problem of anemia. So my first question is to Dr. Bhutta, Sulfi. Your experience extends actually beyond the nutrition field, and we've learned from several of the speakers before that anemia is not just a nutritional problem, but you have also experience in maternal neonatal and child health, adolescent health and reproductive health, and neglected tropical diseases. So we have a lot of engagement of nutrition already in this alliance, but there is a strong need, which was also being identified already, to also bring in the other sectors if we are serious about addressing anemia in an integrated way. So what, in your opinion, are the main challenges and opportunities to do so? Over to you.
Thank you very much, Saskia, for that great question, and a relevant question, because just like many other forms of nutrition, let's take the example of stunting, anemia also represents a syndrome which is reflective of many development challenges in many parts of the world, ranging from poverty, issues of women's health, but also women's education, empowerment. I often comment to people that one of the most important drivers of anemia in many parts of South Asia is family planning. It's just family size. And the fact that maternal depletion syndrome accounts for a lot of not only iron deficiency, but also micronutrient deficiencies in general that contribute to anemia. And then also anemia has a very strong relationship with living conditions and environment, because as we know, a large component of anemia is unresponsive to simple nutrition interventions. If you have constant inflammation, if you have constant issues of low-grade exposure to pathogens, you may not be able to respond to even adequate diets in the same way as other circumstances. And then, of course, there is a relationship between climate change and many of these nutrition issues, of which anemia is one marker. How is that the case? I mean, that is not only related to, as I mentioned, wash living conditions, but also exposure to pathogens that may be emerging and re-emerging in the context of a world that is increasingly now exposed to stresses and stressors of a nature that have to do with the environment. So I do believe that anemia is an enormously important and a sensitive marker of broad human development and the issues and challenges that limit it in many parts of the world. Very recently, Saskia, I helped put out a major Lancet series on optimizing child health and adolescent health and development across the life course. And one of the things, when you look at the conceptual framework as to how everything is linked from pre-pregnancy, pregnancy, early childhood, school-age children, young adolescents and motherhood, it is part of the same continuum. And you can well imagine how nutrition deficits that can be so common in a very sensitive period of early childhood not only impact on propensity to increase risk of infections, but also issues like neurodevelopment, capability of learning, education capacities, and as they grow older, of course, health in general and human capital as we measure it. So to cut a long story short, I think solutions for addressing anemia in women and children in many low and middle income countries need to be more holistic. They need to come from a framework that does not nest the responsibility only in ministries of health or departments of nutrition, that they increasingly bring in elements that come from social protection, that come from education, women's development, as I mentioned, environment, climate change, and other impacts, and also increasingly a focus on monitoring, evaluation, and accountability. So as a marker of development, anemia is a very strong marker of development. And maybe at some stage, as you go through the panel, I may get an opportunity to tell people a little bit about our recent work, which has tried to look at this in the context of how countries across the world have progressed in reducing anemia in women of reproductive age, and what have been the drivers for that change. Thank you.
Yes, definitely. That will definitely be, that will be of interest if you can share those important findings of the exemplars of global health with us. I think, Dr. Butta, thanks for your extensive response. I think if I hear you correctly, in order for us to really work about addressing anemia in an integrated way and bring in new stakeholders, it will be important that we frame anemia not just as a nutrition problem, but more as a marker of overall health, and embedded in this whole pathway of eventually, preserving human and social capital. And I think that's a challenge that's almost like a communication challenge that will be an opportunity, but it will also create an opportunity to bring in these other sectors and these other stakeholders. Is that correct?
Absolutely, Saskia. I mean, you said it better than I, that if it is indeed an issue that has to link to human capital, and capital is not in dollar or economic terms, it's human capital in terms of capabilities and capacities, then anemia is, like linear growth retardation in young children, a very important marker that tells you as to how we can compromise health, well-being, and development across the life course, and not only look at things that can happen in one generation, but can be intergenerationally important. We know how fetal growth is so well related to optimal iron and micronutrient nutrition in pregnancy, and as I've just mentioned a short while ago, to optimizing maternal health in and in between pregnancies. So this is therefore a marker for broader development issues that needs to be taken by the entire development sector, by ministries of planning and development, rather than just by ministries of health or departments of nutrition.
Thanks. Okay, that's clear, and that will be one of the main challenges, I think, to be addressed. My next question is to Mylène Paradis from Global Affairs Canada, and welcome here, Mylène. And of course, Global Affairs Canada is really the leading agency in addressing gender inequalities. Now, with anemia being a particular important public health problem in women and in adolescent girls, how do you see gender inequity as one of the drivers of anemia in women and adolescent girls?
Well, thank you, Saskia. As always, it is an honor to be with global nutrition and health leaders to discuss and explore solutions to the lack of progress in reducing the global rate of anemia, especially in women. Malheureusement, nous savons tous que l'inégalité des genres joue un rôle significatif dans le ralentissement du progrès visant à réduire l'anémie chez les femmes, particulièrement l'anémie par déficit en fer. Nous savons également que la malnutrition affecte les femmes et les filles différemment, et l'anémie par déficit en fer ne fait pas exception. Les femmes et les filles perdent du fer pendant les menstruations, et elles ont des besoins plus grands lorsqu'elles sont enceintes et qu'elles allaitent. Mais mis à part les facteurs biologiques qui prédisposent les femmes et les filles à l'anémie par déficit en fer, il y a aussi la discrimination systémique qui fait en sorte que les femmes et les filles mangent généralement les dernières et qu'elles mangent moins, ce qui augmente le risque de souffrir d'anémie. Understanding why and where women are eating least and eating last, and what can be done to address it, requires a feminist analysis. Male-dominated decision-making, economic and educational disparities, and violent relationships are some of the factors identified to be related to women being excluded from their own health decisions, which includes prevention and treatment of anemia. Nutrition provides entry points to address gender equality issues, such as household power structures and the distribution and control over resources, including nutrient-dense foods. Without a shift at the household level, the prevalence of anemia will continue. In the healthcare system, conducting blood tests for anemia is standard for pregnant women during antenatal visits in many countries. However, routine blood tests to screen for anemia is not as accessible for non-pregnant women and girls. So women should be empowered to request and receive routine blood tests for iron deficiency anemia, and healthcare facilities should be enabled to provide these services. Canada has built an international assistance policy with with gender at its core. Our development work seeks every opportunity to empower women and to integrate gender considerations. This is especially critical for nutrition-related programming. Women should not be eating least or eating last, and only a gender lens to health and nutrition can turn this around. When women are empowered, they are more likely to access health services and nutritious meals for themselves and their families. For decades, Canada has supported partners to tackle malnutrition at all stages of the life cycle, with a focus on maternal and child nutrition. We believe in a twin-track approach that includes high-impact, immediate interventions alongside longer-term interventions that tackle the root causes of malnutrition, including gender inequality. And this work must continue.
Thank you very much for making a very strong case that that women empowerment needs to be integrated into all efforts to address anemia. And I think that's also a clear message that the Anemia Alliance will take at heart. So thank you very much. The next question is for Dr. Bharati, and that actually refers to a program that is already taking this comprehensive approach into account, because India is implementing a national anemia program, which is called Anemia Mukt Bharat. And Dr. Bharati, could you very shortly explain to us the 3x6 strategy of this program and what you have learned about integrating multi-sectoral interventions into one program?
Thank you, Saskia. It's indeed an honor to be a part of this August panel. As everyone is aware that anemia control programs were ongoing in India since 1970s, but the prevalence of anemia continues to be high. And there were supply chain problems and poor last mile delivery and IFA distribution. Iron folate distribution coverage was typically less than 30%. India's anemia control program has been focusing on iron folate distribution because considering that a large proportion of anemia is because of iron deficiency. But there were state level variations and some states were showing better progress than others. And typically some of the states which were showing better progress had some of the characteristics such as high level of political commitment, they had target setting, and there was better interdepartmental convergence. So the current program, which is called Anemia Mukt Bharat, which translates as Anemia Free India, builds upon these experiences of the states which had successfully demonstrated lowering anemia prevalence. And the 6 into 6 strategy means that there are 6 groups of beneficiaries, which include children 6 to 59 months old, children 5 to 9 year old children, then adolescent girls and boys, then women of reproductive age, pregnant women, and lactating mothers. So these are the 6 groups of beneficiaries. And then there are 6 interventions which are covered under this program, which include prophylactic iron folate supplementation. There's also testing component, which is new. So testing of anemia using digital methods and point of care treatment is included. There's deworming, there's intensified year-round behavior change communication campaign. There's also a focus on delayed cord clamping. There's mandatory provision of iron folic acid fortified foods in public health programs. And there's also a focus on addressing non-nutritional causes of anemia in endemic pockets, with special focus on malaria, hemoglobinopathies, and fluorosis. So there is a recognition that anemia is not only because of iron deficiency, but has multiple causes, and it's important to address these causes also. And there are 6 institutional mechanisms which include inter-ministerial coordination. There is also a focus on convergence with other ministries. There is and National Anemia Mukt Bharat unit. There's a focus on strengthening supply chains and logistics, and there's a Anemia Mukt Bharat dashboard and digital portal, which is supposed to be a one-stop shop for anemia. So this 6x6x6 strategy takes into account the multifactorial causes of anemia and the need for multi-sectoral convergence, better coordination between the different ministries, as explained by the previous speakers. So I think this program addresses the multifactorial determinants as well as emphasizes on multi-sectoral coordination. Thank you.
Thank you very much, Dr. Kulkarni. That's that's very impressive that this is already taking place as we speak in India, and I'm sure there's a lot of interest to share the lessons learned and learn from that experience and see if it can be replicated in other settings as well. So our next speaker, and I'm very pleased that he was able to join us, is Dr. John Raqpa, and let me spend a little bit of time to introduce him to you, because he hasn't been introduced when we were in the panel. He's the Deputy Director and Head of the Micronutrient Deficiency Control in Nutrition in the Federal Ministry of Health of Nigeria. Mr. John has 25 years of experience leading projects in biofortification and home fortification with micronutrient powders, and he's a member of technical working groups for nutrition policy, guideline development, and food fortification. So, Mr. John, in Nigeria's last demographic and health survey, which was held in 2018, 68% of children and 58% of women were anemic, and these are astonishing high figures. But this survey also assessed indicators on the likely causes and risk factors for anemia, for example, malaria, sickle cell disease, the coverage of WASH interventions, education, diets, etc. Can you share with us an example of how Nigeria is using these data to address anemia in a more holistic way?
Thank you very much, Lisa. Well, first of all, let me start from apologizing for joining late. And I've been trying to connect. I was having a network problem. In fact, the issues you raised, thank you. The issues you raised from the survey of 2018 is quite right. The Nigerian government have rolled out a set of interventions. Though before then, these interventions has always been there, and most of the interventions are sectoral interventions. Like from the nutrition sector, the government of Nigeria have been able to come up with micronutrient deficiency guideline. And anemia deficiency can be, from the nutrition aspect. So in order to address it, we have come up with a micronutrient deficiency guideline, where we have a lot of strategies, like supplementation of iron folic acid to the pregnant women in Nigeria is free of charge. Every pregnant woman is expected to receive iron folic acid free of charge in order to address the iron deficiency during that period. Also, we have the strategy of which is this strategy is based on education sector, whereby adolescent age, both those that are not married are supplemented with iron folate, both in school and out of school. We have that going on in Nigeria. We also intervene through home fortification, what we call home fortification, using micronutrient powder. In this case, most of the complementary foods we have in this part of the country are deficient in iron. So in order to address it, during after during 6 months of age of a child, because here in Nigeria we practice exclusive breastfeeding from 0 to powder. This micronutrient powder, its target is the iron deficiency, to improve the iron content of that complementary food of a child. And it runs from 6 months to the age of 5 years. That's under 5. So within this period, this macronutrient powder, for the standard Nigeria have chosen, we have a 10 milligram. Each packet of macronutrient powder contains 10 milligram of iron, which if the child takes it judiciously, will be able to take care of the iron need of the child during that time. Also, for pregnant women or lactating mothers, we distribute free iron folic acid for them during that period, and also ensure that we give them the worming tablet so that it will take care of the worm infestation, which competes, which is also a risk factor, during this period. Besides that, from the malaria sector, that's the public health sector, Nigerian government has been able to ensure that, to ensure that lean is distributed, that is long-lasting insecticidal net, is distributed free of charge to every family. Every family gets at least one net, and they are being encouraged to sleep under this net to avoid mosquito bites.
Thank you very much.
Which is also a risk.
Mr. John, I'm sorry to interrupt you.
Is my time up?
Yeah, well, sometimes your connection is a bit of poor quality, so but we could follow most of what you said. And I think it's impressive to see the comprehensive package of interventions that you're implementing in Nigeria. And it would be interesting to learn more from those experiences again and see how this can be integrated into even a broader package of interventions, also addressing the other non-nutritional causes of anemia. I would like to now ask a question to Sumra, because you've heard about countries such as Nigeria that have data on the different drivers and risk factors of anemia. And can you tell us what are some of the ways that they can bring together these multiple sectors, such as social protection, food systems, health systems, to address anemia more comprehensively? So to go from the data into, engaging these multiple sectors into an integrated way.
Yeah, there is need for us to have, intersectoral collaborations.
Yes, I would like to also ask Dr. Sumra the question, who's also on the panel, based on her experiences working in the World Food Programme in the West Africa region. And then I will get back to you with another question later on, Mr. John. Thank you very much.
All right. Oh, thank you.
Thank you.
Thank you so much, Saskia. First of all, thank you for having me. It's really a pleasure. So I know you've asked about Nigeria, but I think similarly, we have a lot of the same risk factors in Pakistan. For example, iron deficiency anemia is one of the most common forms of anemia that we see. And I think that's also been echoed by Dr. Bharti from India. So I also wanted to mention that when we look at the prevalence of anemia, it hasn't really changed over time, particularly in Pakistan, and we have quite a lot of data over the past 20 years. It's remained a public health concern, and unfortunately, the prevalences remain above 50% as for children, as well as 40% for women of reproductive age. Now, in terms of I heard this great program that's happening in India as well as in Nigeria. Pakistan also has a similar program. It's called the National Lady Health Worker Program. And similarly to Nigeria as well as India, we do provide supplementation, we provide deworming, we provide health and nutrition information, and much more. And it is mainly targeted to pregnant women and children under 5. So again, as you can see, adolescent girls end up being, a gap, as well as lactating women end up being a gap. In terms of the program overall, I think what we have experienced is that there are large gaps, especially populations that are vulnerable and that are vulnerable and poor. So we are trying to find innovative solutions to reach those underserved populations. And one that we've seen that has been very effective in Pakistan is linking in the National Social Protection Program. So the government of Pakistan in 2019 leveraged the National Social Protection Program and developed this program called Noshanama. It's a nutrition-sensitive conditional cash transfer program. It is aimed at preventing malnutrition in pregnant and lactating women and children under 2 belonging to households in the 2 lowest wealth quintiles. Now, yes, it targets malnutrition, but the great thing is that the services that are provided under this program also play a role in reducing anemia. So I feel like, other panelists have mentioned leveraging social protection. So that's one thing that we're doing, and I think it's working out quite well. Yes, it's in early phases and we have to wait for the findings, but that's something that we feel has been quite effective in our region. Now, as I mentioned, it shows great promise. However, this program, and I feel like similar programs, do tend to rely heavily on the health sector, especially the capacity of the health system. And therefore, I think there's a need to invest within the health system to ensure that we have adequate supply of nutrition and health commodities, as well as improving the capacity of the health workers in order to ensure that we increase impact of the programs that we are implementing, like Noshanama, for example. Another thing I wanted to mention is in addition to relying on social protection, there's also a need that we bring in other sectors, like other panelists have mentioned, that bring in interventions such as nutritious school meals and supplementation, particularly at secondary schools where we can approach and reach the adolescent target groups. Another thing that we feel that I feel would be really important is legislation for mandatory fortification of wheat. Often we see this in a lot of countries. Oh, sorry.
Yes, I think you were frozen for a minute, but can I ask you to wrap up your answer because we are a little bit running out of time? Yes.
Sure, sorry. So I'll just wrap it up. I think there's, like I said, political, multi-sectoral nature, political leadership is very, very important. So I'll end with that. Thank you so much.
Thank you very much. And for your question. And unfortunately, we are running a bit short of time. So I would like to ask the next panelist, Dylan Walters, to give a brief answer if possible. And also I would like to encourage all the participants. There's lots of questions in the Q&A chat, which is wonderful. It means that this is really a topic that is close to everyone's heart that's listening in, and that there's lots of interest in the work of the Alliance. Please be assured that we will capture all the questions that are in the Q&A chat, and we will find a way of addressing these questions through another means and get them to you when we submit the proceedings of this webinar. So please don't feel discouraged if we are not able to address these questions in today's panel. So a final question is for Dylan Walters about the return on investment. You've been working on this nutrition investment framework with the World Bank. And what is known about the return on investment in anemia prevention and treatment? And what are the costs of not investing in anemia?
Thank you very much. Previous speakers have mentioned several health and human capital consequences associated with anemia. Early estimates from a new modeling tool that we were developing at Nutrition International suggest that the global economic cost of anemia may be nearly $1 trillion of losses annually, which is equivalent to over 1% of global gross national income. This is a tremendous cost. and could be even greater if we include non-nutritional causes of anemia. And the losses also disproportionately affect low-income and lower middle-income countries, further compounding existing wealth inequities. And notably, the economic losses due to childhood anemia may be as much or greater than the economic costs of anemia in women, which supports the argument for creating a target for anemia in children within the WHA and SDG targets. The good news, Saskia, is that we have evidence-based, high-impact, low-cost interventions ready to reduce the prevalence of anemia. In 2020, Scott et al. Analysis found that investing in only 5 very cost-effective interventions, IPTP for malaria, IFA, supplementation for non-pregnant women, multiple micronutrient supplementation in pregnancy, iron fortification in salt, and iron folic acid fortification in staple foods, as well as strengthening health systems and infrastructure, would together avert 379 million cases of anemia in women at a cost of $1.5 billion per year across LMICs. In the World Bank Investment Framework for Nutrition, we estimated that investing in a similar package of very cost-effective interventions would generate an economic return of $12 for every $1 invested, suggesting that investing in anemia prevention is good value for money. Certain interventions for preventing anemia in children, including micronutrient powders, are also cost-effective. Now, I acknowledge that achieving the WHA and SDG target will require major contribution from other sectors and to address the multi-causal pathways that lead to anemia. More research and integrated planning, programming with SSNPs, SRHR, agriculture education are needed to advance this contribution. It is clear, however, that the scaling the reach and financing from domestic and donor resources for evidence-based nutrition actions, as outlined earlier, to unprecedented levels is a clear priority for this global action on anemia, global action plan on anemia. Thank you.
Thank you very much, Dylan, and thank you very much for also keeping your answer very short. I would like to use the remaining time to for a couple of questions that have been posted in the chat, particularly related to this new alliance or Anemia Alliance, and see if one of the panelists can answer these questions. I would also like to emphasize again that we will find a way to communicate to you the answers to the questions that we cannot address in today's panel after this webinar. So you will hear from us on the questions that have been addressed in the chat. But one question that was asked by Sophia about this initiative, which is she thinks a much needed initiative, is to really how this relates to how this alliance can help to inform the work that's already ongoing in the countries. And I think this is a question that I would like to maybe first ask to Dr. Bharati. In your opinion, how can this new alliance and or the global action plan help to support the efforts of the India Anemia Mukt Bharat program?
Yeah, thank you for this question. I think we are still using one-size-fits-all option, and there is also a focus on universal and mandatory approaches. Whereas when we think of test and treat approach, we really are struggling with point of care testing methods for hemoglobin estimation as well as measurement of other iron biomarkers if we have to treat anemia based on the causes. So there is really need for better diagnostics for point of care testing of hemoglobin as well as other biomarkers for micronutrient indicators, because that's the way to go forward by going towards precision nutrition so that we will be able to address the exact cause of anemia. In that sense, there is a strong potential in this alliance to help. Thank you so much.
Thank you very much. And I would like to ask the same question to Mr. John in Nigeria. How can the work of the alliance help you in Nigeria to better streamline the programs addressing anemia? Can you please unmute yourself? Yes, thank you.
Yeah, thank you. Well, in Nigeria, we are actually looking forward for the alliance because, you know, Nigeria is a very large country and most of the innovations are earlier enunciated does not actually cover the whole country. So it's going to be a welcome idea and Nigeria is going to be part of it and to ensure that this anemia is eliminated completely because it's actually a big issue in the country. And most of the interventions I earlier mentioned are not, you know, we still need help, you know, to make it, you know, go around the country so that everybody will be a beneficiary. Because our population is actually very large and the government is doing well on their part. Thank you.
Thank you. Another question is for Milan. In your opinion, how, you know, you were addressing the importance of taking into account gender inequity, but how, in your opinion, should this be mainstreamed throughout the work of the Alliance to make an impact on reducing anemia at the country level?
Thank you, Saskia. I think this is a very key question. Mainstreaming gender at country levels is critical in meeting the WHO anemia target, in my views. They should be done in every corner of the program and policy work of the Alliance at local, regional, and national levels, and in the design, implementation, operations, and financial management and budget allocation. Women and girls should be an integral part in decision-making at all levels, from community health committees, from health committees to executive boards. Women and girls should be included in all stakeholder consultations. In addition, sex and age disaggregated data should be collected and reported for all applicable indicators of programs targeted at prevention, diagnosis, and treatment of anemia at all country levels. Improving gender expertise at all levels of government for effective policies and program implementation to mitigate anemia is equally important, as is ensuring organizations engaged in anemia mitigation have sufficient gender expertise and capacity. Policies should be put in place to ensure the safety of nutrition, health, agriculture, and humanitarian workers, especially women. And it is equally important for countries to focus on areas of nutrition that overlap with health, humanitarian assistance, climate smart solution, sexual and reproductive health and rights, and food systems, as was previously mentioned by other panelists. As for Canada, we will continue to work with existing platforms such as the Sun Movement to leverage collective voices to raise equity and women's empowerment on the global nutrition agenda. But we will also engage with emerging opportunities such as the Alliance for Anemia Actions, which has a great potential to accelerate progress in women's nutrition. Canada will continue to work with partners to accelerate improvements towards the 2025 WHO nutrition targets by placing emphasis on scaling up high-impact, low-cost interventions that address undernutrition and micronutrient deficiencies. This work also supports multi-sectoral innovative delivery platforms and strengthens country capacity. Ensemble, nous pouvons accélérer l'atteinte de la cible de l'Assemblée mondiale de la santé de réduire de 50% d'ici à 2025 l'anémie chez les femmes en âge de procréer. Il y a évidemment encore beaucoup de travail à faire, mais nous pensons y arriver grâce aux efforts des différents partenaires qui ont l'égalité des genres au centre de leurs préoccupations. Merci.
Thank you very much. And thank you very much to all the panelists for your important contributions to the discussion today, clearly demonstrating that, you know, there's still much to do, but that if we work on this together, that we can really make progress on this important public health problem. I would like to just emphasize again that I see lots of questions in the chat that relate to research. There are also questions about, can there any experiences being shared of countries that have been successful in the reduction of the prevalence of anemia? And yes, I think, you know, the exemplars of global health program that Dr. Sulvi Butta has been involved in, has been evaluating these. We will be addressing the answers on these questions, as I said earlier, through other means, through emails, but also I think it demonstrates the importance of this integrated research component that's also part of the Alliance, which will address some of these critical questions that have been addressed in the chat, and at the same time make sure that the responses of these questions are immediately being integrated into program activities. I think that's also of critical importance if we are to take this program serious. So with this, I would like to close this panel session. I would like to thank again the panelists of today, and I would like to hand over back to Mandana for the remainder of this webinar. Over to you, Mandana. Thank you very much.
Thank you very much, Saskia, and all the panelists for this rich conversation, for sharing your experiences and insights. And it's really remarkable to hear your reflections on the diverse causes of anemia, the action that's needed, and how we can really use this global action plan and the collective of the Anemia Alliance for making sure that we support the countries in their efforts for reducing anemia. And it's also encouraging to hear, you know, we are looking at anemia not just as a public health issue alone, but also as a gender issue, as something that has been really disproportionately affecting women and young children. So with that, we are actually coming to the end of our program today, and I would like to hand it over to Dr. Victor Aguayo, Director of Nutrition and Child Development at UNICEF, for the closing remarks. Victor brings 30 years of policy, program management, and humanitarian experience in maternal and child nutrition in Africa, Asia, Latin America, and globally. He's been championing for nutrition, and he's now going to share with us his words of wisdom on the Alliance and provide closing remarks. Victor, over to you.
Thank you, Mandana. Let me check that you can hear me well.
Yes, we do. Thank you.
Thank you very much. Dear colleagues and dear friends, it truly is a pleasure to be with all of you today, to be with the Alliance, delivering on this commitment by WHO and UNICEF to accelerate progress towards reducing anemia in children and women, with emphasis on low and middle income countries. The Alliance that we have been discussing today and the Global Action Plan of the Alliance are therefore important steps towards the global target of reducing anemia in women by half and addressing anemia in children and adolescent girls. These are the most vulnerable groups in the populations that we care about, as we heard today. I think it is important to remember and to remind everyone that since the year 2000, the world has reduced the proportion of children suffering from stunting by 1/3. And the number of children who are stunted by 55 million. I am mentioning this because this remarkable achievement proves that positive change for complex nutrition issues, as Professor Butta was reminding us, progress for complex nutrition issues not only is possible, but is happening at scale across regions and across countries. So this is the good news. However, as we all know, there are new forces that are threatening the progress that we have made in the past 2 decades. Threats such as globalization and urbanization, increasing poverty and inequities, the climate crisis, the impacts of the pandemic, rising food crisis, and ethical marketing practices, and of course, increases in conflict, not least the war in Ukraine. Therefore, there is much work to be done, and ending anemia in children and women is a case in point, with more than 1 in 3 women in the world and almost 1 in 2 children under 5 living with anemia. This is simply unacceptable. It truly is a shame for all of us and the global community. It is important to remember and to remind others that iron deficiency accounts for about half of the global burden of anemia. Hence, addressing anemia calls for a nutrition plus response. Multi-sectoral action and coordination to ensure that children and adolescents grow and develop to their full potential is of the essence. Multi-sectoral action and coordination to ensure that all women live a life without anemia, a life with greater dignity and well-being is of the essence. I believe that more than ever, we need to frame anemia as a barrier to children's brain development, school readiness, learning performance, and prosperity, but also as a barrier to women's right to equal opportunities in life. More than ever, we understand how combined actions through the food, the health, the water and sanitation, the education, and the social protection systems contribute to improved nutrition. We need a multi-systems approach to addressing the more complex issues of nutrition in the world. And more than ever, we acknowledge the role of nutritious diets, essential services, and positive practices in protecting and supporting survival, growth, and development in children and reducing anemia in children and women. So with the Alliance for Anemia Actions, our collective commitment is to ensure that all children, adolescents, boys and girls, and women benefit from diets, services, and practices for the prevention and management of anemia. Today, we have heard from a selected number of key actors why addressing anemia is crucial, how they have made progress, and what they expect from the Alliance. Now we call on countries, all countries, to leverage the food system, the health system, the water and sanitation and education system, and the social protection system to address the key determinants and the key drivers of anemia in children and women. We call on stakeholders, both public and private, to join forces with us to accelerate actions and investments in cost-effective and gender transformative solutions to rapidly reduce anemia in children and women. And finally, we call on all of you and those who are not with us today to join the Alliance. And we look forward to your engagement with WHO, with UNICEF, and with our partners. Please do take note of the email address and the website on screen now, where you can go to signal your interest in joining the Alliance. Together, we will support the scale-up of priority actions. Together, we will build on existing opportunities and new opportunities that we will create. And together, we will accelerate progress towards our resolve to eliminate anemia for every woman, for every adolescent, for every child, everywhere. Thank you, everyone, and back to you, Mandana.
Thank you very much for these energetic and energizing remarks. I would like to now close my part in this agenda and hand it over to Dr. Francesco Branca to finalize the event.
Yeah, well, thank you very much. Really, I would like to, on behalf of WHO, to thank first and foremost our partner UNICEF for having made this commitment and having walked the talk on this commitment. And then all the other partners, Macronutrient Forum, Nutrition International, USAID, and all others that have contributed to the discussion today and to the establishment of this very important collaboration. Thanks, colleagues from the countries who are giving us the right direction to really understand what the issues are and what we should work on. I join Victor in asking you to spread the news that this is happening, and we really look forward having partners, particularly in sectors that we need to work on, the infectious diseases, all the other areas that will actually help addressing anemia, sanitation, agriculture. We need your contribution. So I join really, Victor, in asking you to spread the voice and express your interest in joining today. And again, thank you very much to all, and I hope to see you at the official launch of the Alliance, which we're planning to have in September. Thank you very much. Goodbye.